All right, I guess it's about that time. We'll go as I run down here. We'll go ahead and get started. This morning, I have the pleasure of introducing our speaker, Dr. Russell Jennings, who needs no introduction in this forum. But Rusty is associate professor of surgery at Harvard Medical School. He did his medical school and residency training at University of California, San Francisco, and of course did his fellowship training here at Children's Hospital. Rusty's history as an academic surgeon has evolved significantly over the years. His CV reflects involvement in a lot of very interesting changes in the field of pediatric surgery over the last several years, including everything from fetal wound healing to fetal tracheal occlusion, fetal surgery, and in more recent years, of course, long gap esophageal atresia and the Fokker process. Today, Rusty will be talking to us about something that is not yet in the pediatric surgery textbooks, but probably soon will be, and that is the surgical management of tracheomalacia by means of the tracheopexy. So we look forward to hearing an update in this regard.
Good morning, good morning, good morning. I have no interest. So the E program, as we ended last year, when we had this sort of similar thing, we ended with the evolution of the E program, which is spinning up. And we've gone from all these little programs. We must have, Dory, tell me, 15 little programs that we're doing. We're starting caustic ingestion program. We have congenital stricture program. All these little wedges, each one of which is expanding. And it's gotten to the point where we can no longer give you a meaningful lecture about what the EAT program does, because it would just be a superficial. So we've exceeded all expectations already. So let's just change gears. I'll tell you about pediatric tracheomalacia. There's a mini symposium on pediatric tracheomalacia just last year. This was written up by the group at Children's Hospital Philadelphia. And it's so interesting because it said that their experience that tracheomalacia will resolve or improve significantly over the first 2 years of life. And aortopexy is the mainstay of surgical intervention, but the collapsible segment of the airway remains. That was just 2015. So I went back and looked at the surgical textbooks. These are all our major textbooks, or some of the major textbooks for pediatric surgery. And here's one. This is the textbook called Pediatric Surgery. Most tracheomalacia can be treated conservatively, which always irritates me, the word conservative, because sometimes the most conservative thing is a big operation. But the natural history of the condition is significant, spontaneous improvement after age 1 year. And that comes out from Keeley and Spitz from 1987. And they said that most infants with tracheomalacia do not require surgical intervention. They said that the cartilage rings will then develop significant rigidity to support the lumen without collapse. I'll tell you, they're wrong on all accounts, and I'll explain that why. So the principles of pediatric surgery: growth of the trachea relieves symptoms by the age of 2 years. Surgical directives in pediatric surgery. Tracheomalacia is not severe enough to cause obstruction. Inspiratory stridor is worse on exertion, can be tolerated for a period of time. Tracheomalacia is actually expiratory stridor. So experts should write about what they're good at. So it's not what you don't know that gets you into trouble. It's what you know for sure that just ain't so. So this article just came out. I mean, literally just came out. And I would advise anybody who takes care of esophageal atresia patients to take care of this. And what they did out of the Cleveland Clinic was look at 43 patients, an average of 8 years old, between 3 and 20, and they did all these evaluations on them. And they reported these sort of long-term. 8 years is not a long-term. But I thought it was really interesting to look. This is just the respiratory issues. It's a fairly long and comprehensive article. But it shows that the majority of them have respiratory issues. If you look at them on chest CT, about half of them have tracheomalacia that's diagnosable on chest CT. And chest CTs are actually designed to hide tracheomalacia. So if you're seeing on a chest CT, it's interesting. And a fourth of them have bronchiectasis. If you look on bronchoscopy, the majority of them have tracheomalacia, tracheal stenosis, recurrent TEFs, and bronchomalacia. So what's bronchiectasis? I'm a pediatric surgeon. Is that something that old people die of? Well, it turns out it happens in kids too. This is a Cochrane review, just came out. Bronchiectasis is a respiratory disease characterized by abnormal dilation of the bronchi. Presents typically with chronic productive cough or chronic wet cough in children. And a recurrent exacerbation significantly impacts activities and quality of life. It can lead to recurrent hospitalizations, severe lung function impairment, respiratory failure, and even death. And this is non-cystic fibrosis patients. We've just reviewed a bunch of our patients. I think we reviewed 450 of our esophageal patients, esophageal atresia patients. And we found there's a strong association in the EA patients with respiratory anomalies, including, not interesting enough, a third or more of them have tracheomalacia. So our goal of this lecture is to talk about tracheomalacia. We can no longer discuss everything we do and eat, just a little slice from now on. And we'll talk about the dynamics, talk about the thoracic anatomy in relation to the trachea. We can talk about a classification system that we use and some of the therapeutic concepts and what we do for surgery. So some of the concepts you want to think about is, first, tracheomalacia means you have intrathoracic tracheomalacia, means you have reduced intrathoracic expiratory airflow. It's a lot of multisyllable words, but you hear these kids because they have the brassy cough, the tough cough, or this expiratory rhonchi. And it's really caused because the anterior wall and the posterior wall are vibrating against each other. And that sort of closing causes reduced airflow, but also means the kids can't clear their secretions. Their secretions build up. And that, if you can't clear the secretions, you get prolonged URIs, prolonged recovery from a URI, and pneumonias. You also have exercise limitation. You don't move air, you're doing exercise. We know about ALTs and blue spells and hypoxic episodes that cost kids a few brain cells. But you also understand eventually can develop things like bronchiectasis, becomes an irreversible sort of self-fulfilling prophecy of recurrent pneumonias and even death. So precision is important, and airway obstruction probably doesn't usually occur. I think of obstruction as something that's completely occluded, and that would be sort of a one-way deal for these kids. But really what is a variable impedance or variable resistance to airflow, and it changes depending on the part of the respiratory cycle and the airflow at the time. So it's really sort of a dynamically changing impedance. Tracheomalacia is getting more and more interest in the literature. In 2009, all these new terms showed up in PubMed to talk about tracheomalacia. So now it gets a little confusing. You're talking about expiratory dynamic airway collapse, tracheobronchomalacia, and all these words. And the problem is that the airway is actually not soft. So all the malasic terms you have to throw out. And if it's collapsed, it's really not totally collapsing. It's dynamic. So, and it's not stenotic, it's dynamically stenotic. So unfortunately, the word tracheomalacia is sort of entrenched in our literature, so we're just going to have to use it, but it's not a soft trachea. It's actually a dynamic impedance of the airflow, and that, of course, is not specific enough. That would include things like vocal cords and laryngomalacia, so we stick with the term, understanding that it doesn't actually mean anything about what we're doing. But so let's talk about some of the physics and physiology. When we take a deep breath, our ribs rotate forward, they rotate out, our diaphragm drops, our shoulders rise, and that drops intrapleural pressure, which translates that pressure to the parenchyma, which translates that pressure to the mediastinum, and all the air starts moving in. And when we want to push the air out, we want to exhale, all those things reverse. We start from the outside and push all the air out. And that increases the pressure on the mediastinum. Well, we know a couple of things. Bernoulli's principle, we remember all this from high school or whatever. We studied this. The faster the airflow, the lower the air pressure, which always seems a little confusing until you understand that. But, and you can see here, this is just a little Bernoulli's thing showing that when we are moving air through our trachea quickly, the walls want to sort of collapse because the outside pressure is higher than the intraluminal pressure. But because this image on the right is showing us that the cartilages around the trachea sort of keep it from collapsing. They're stiff enough that keeps it from collapsing, except for that little membrane on the back, which is a soft, it's a muscular, but there's not much tone to it. It's a little membrane on the back, which has some attachment to the esophagus and some to the spine, loose areolar tissue, but it's essentially floppy. But if it's a small proportion of the circumference, it's not going to cause much of a problem. And this just shows you normal aerodynamics. You can see the normal rings right here, the normal C-shaped rings, and that posterior membrane is going in and out with breathing, and it's not changing airflow very much. You can see in this kid, he has, I don't know if that's going to work, he has cartilage that are different. They're not C-shaped. These are bow-shaped, like a bow and arrow bow, and that membrane is a predominance of the circumference and can intrude fairly significantly into that kid's lumen, causing restriction in airflow. This is a C-shaped cartilage that's sort of collapsed off to one side a little bit, and when this child breathes, you can see that the posterior membrane really intrudes into the lumen, and in fact, at some point, totally collapses. And that prevents the movement of air as well as the movement of secretions out of the airway. Well, you can actually study this in the physics lab. You can set up a little chamber, a little camera on one side, to see how big the chamber is. You can vary the pressure on the outside of the tube, and the higher the pressure, the narrower the tube gets, and we can look at what happens. And this is how you get PhDs. You document that when you make the tube narrower, you get less airflow, and that's the upper thing. And you can actually show in the lower chart that the more restrictive it gets, when you push harder, you actually don't get much increase in airflow. So very, very predictable, but now documented in numbers. We see this in the pulmonary functions lab when Larry Ryan and his team do some PFTs, and we can see that this I wish I had a pointer, this flow on the top gets cut off. Right here. This is when you exhale, and this is what happens when you can't fully exhale, but you can still inhale fully. And here, if you're stenotic, you have a cutoff of both. So you can see that it's not a static narrowing, but it's actually dynamic narrowing, mostly on exhalation. So tracheomalacia can be either regional or generalized tracheal collapse. Can include the bronchi, can include the small airways, and has varying degrees of airway resistance, and it can be a severe or chronic cough. It can cause recurrent infections, exercise intolerance. We've talked about some of the more serious issues. But there's really no standard way of classifying it. If you look at it, if 5 people look at some kid with collapsing airway, some will say it's okay, some say it's not even there, they'll totally miss it, and some people say it's severe. Nobody's going to be able to give you a number. So we need some sort of a precision that we can understand, and we can actually see what our treatment is doing any good. So we want to go to some of the elements. First is the shape of the cartilages. The cartilages are supposed to be C-shaped. That's the way mine are, that's the way yours are, presumably, with a very small segment, less than a fourth of it being the posterior membrane, somewhere around 20%. U-shaped cartilages have a longer posterior membrane, and those with bow-shaped cartilages have a very long posterior membrane. And with that membrane is floppy, that can have more intrusion into the airway. There's also a character of the collapse. We can have anterior collapse, typically caused by one of the vessels or a cyst or something in the mediastinum. And these are predictable in some kids and unpredictable in others. But that's not like it's a soft malastic collapse. It's that shape, and it's going to stay there when you take the blood vessel away. And then there's the posterior intrusion. The ring's fine, and the posterior membrane comes in and out with the respiratory cycle, and then they have combined when both are occurring. And so here's a kid with some posterior intrusion. You can see the posterior membrane back there, right here, intruding into the lumen. And here's a child, the video's not working for some reason, but you can see the anterior collapse in the distance where the wall, the anterior wall just sort of comes down like a little shelf. So why is character important? Because the posterior intrusion is very dynamic, changes dramatically with the respiratory cycle. And the anterior collapse is fixed. It just stays there. You may see some pulses or some blood vessel there, but it's not moving much. So it's really a stenosis. And the combination of a fixed stenosis plus a dynamic stenosis or narrowing is what causes the problem in some of these kids. Here's a child with both. You can see that's the right main stem, which looks pretty good. As you come back, you can see there's the anterior collapse and there's the posterior intrusion. So that kid has both. And we see that a lot. So we can talk about, now we have the character, what's the degree? Well, the degree tends to be a limitation of airflow. So we'll say, if this was normal, what % of normal is the airway collapsing? And we have to make that up. That's sort of a mental thing, because in the scope everything's so distorted. But you get used to it. You do enough of them. So normal for an adult, when you cough, your airway collapses about 50% posterior intrusion at most. So that gives you sort of a rough idea that 50% is probably not just critical decrease in airflow. And here's a child who has has a pretty critical airway, tracheostomy dependent. And if you come down here, you can see there's the anterior collapse and there's the posterior intrusion, both of which are sort of fixed. That's what she's breathing through, and that's all she's breathing through. So now we understand the character. We stand to degrees. Now we need to get to the location because the location matters. And so we've divided the trachea into many segments. T1, proximal and distal, T2, proximal distal, T3, proximal and distal, the carina, and then L1, L2, L3 over here. And that's important that it's divided in little segments, and the right and left is proximal and distal. Why do we divide into so many pieces? It's just collapse, because every part of that trachea is different. It's not just a tube. All these structures are surrounding it. And if you go to the proximal T1, it's got the esophagus behind it because there's a cricopharyngeus musculature holding it right there. Distal T1 has the esophagus behind it, but it can actually be moved out of the way. And you go down, proximal T2 has the innominate vein in the front and the esophagus behind. Distal T2 has the innominate artery crossing it. T3 is the aorta crossing, which is anterior and then lateral, and then carina is the pulmonary artery, and it goes on. Every segment has something different in front of it. So this reason that matters is because those structures are impacting how the trachea functions. We looked at this, we said, well, so we're dividing all these numbers, we have all these scales, what's it all mean? So Sig went out and looked at it all. She did this little deal where she added up the segments and the narrowing and what matters. And what we found out was that before surgery, these kids who were symptomatic had a scale of about 12. After surgery, a scale of about 4. So our scale, when you add up all the numbers, seems to make some correlation with outcomes, and surgery also impacted it. So we think it's a clinically significant rating scale. So is there another way to do it? What else can we do to do this better? Because if we're doing bronchoscopy, we have an idea of the collapse on a dynamic scale. So what we want to do is understand the structures around it. Well, the only way I know how to do that currently is with the CT scan. MRI is sort of not yet, and it's getting close though. But we need to make sure there's no endotracheal tube in it because that distorts the airway. Just do it with an LMA. And we did this study and we compared CT and bronchoscopy. Here's a CT scan showing that on inspiration the trachea is open and on expiration the trachea is occluded. And we can do the nice 3D reconstructions. These 3D recons are the best things in the world because the parents can understand them. We say, this is the lung, this is the airway. When you breathe out, you don't have any airway and you can't get the stuff out. And they go, oh my God, they get it. This is when you do these little flybys, you do 3D recons. I'm not sure they're worth much, but they're entertaining. And this just shows the same thing on flyby, and this is the same view of bronchoscopy of the same kid, same thing. When we look at the two, we compare them, they are mostly correlated really well, except at the very upper trachea where the bronchoscopy is much better because we don't have all the problems with the kids who've had tracheostomies and endotracheal tubes in place. And on the very low airways, in the main stems and more distal, the CT is better because we're just not good at taking a rigid tube and getting it all the way down to those airways. So actually they're complementary. We need both for the majority of these kids. And unfortunately, the radiation doses are dropping like a rock, and they're down to just 1 millisievert per CT scan, I understand, which is equivalent of flying across the country in an airplane. So we look at all this complicated anterior anatomy, and we look at the posterior anatomy. What's one of the things we worry about? We worry a lot about an aberrant right subclavian artery. I know some people talk about what is it. There's actually many variants of it, whether it comes off the top of the arch, or the distal arch, and where it crosses. But this matters because this shows a little bit of, can act like a pincer and actually compress it like a vascular ring in some configurations of the aberrant subclavian artery. So posterior to the trachea, there's not supposed to be much. You're supposed to have this nice wide membrane in the back. Back of that's supposed to be the esophagus and thoracic duct, spine, and some other blood vessels, nothing of major physical import. But when that artery's back there, it changes this whole dynamic. So we have now a little bit of a concept of tracheomalacia and the tracheomalacia surrounding structures. Let's talk, what's our goal? Well, our goal is to provide support for the trachea to prevent the dynamic collapse. And we've just learned the majority of the problem is the posterior membrane. That's going in and out. We want to open up any narrow areas. We want to be very careful about the surrounding structures, use them when we can, move them when we need to. We I think what will happen once you change the configuration of the trachea, it's going to sort of get stiff in this new position. We want to allow this trachea to grow with age, because let's face it, kids grow 20-fold, something like that. So here's the tracheomalacia. So this is Dr. Folker's introduction to us early on. I've always been interested in tracheomalacia. I've written about, before I even met him, about thoracoscopic and thoracotomies and how to do tracheomalacia. And his introduction was, well, just do a sternotomy, do it from the front, bring everything straight forward. And it turns out, in his version of a tracheomalacia and aortopexy, for tracheomalacia, you're not just lifting the aorta. You know, some people just put a stitch in the aorta and say, gee, aortopexies only work a third of the time. It's true. If you only put a stitch in the aorta, if you do an aortopexy, if you're purist, it only works a third of the time. But if you lift everything up, it works much better. Well, why don't you just do a tracheostomy? That's the world's most common treatment for severe tracheomalacia. Well, because it's mortality. I just lost a baby 2 days ago. Came in with a giant fallacy with ectopia cordis. Family moved all the way from Chicago to get treatment here, and while waiting for an OR date, the child died from a tracheostomy occlusion. So it's a devastating, tracheostomies are not, I'm not a friend of tracheostomies. Can we use stents? This is what Dr. Filler started way back in the 70s. I said, you know, we can open up these collapsing areas. We'll just put in a wire thing, a little fence in there, we'll hold everything open. And in fact, it works. It holds everything open until the granulation tissue starts creeping through it. And then you end up with the granulation tissue narrowing, which is even harder to deal with. So then you use coverage stents, and they have more problems. So tracheal stents aren't all that useful. All these have their use, and you have to be very careful. One of the problems with stents is they do tend to push on the surrounding structures, and if the surrounding structures includes an artery, and you punch a hole in the artery, that can be a lot of drama. So the aortopexy effect, in theory, is to take this collapsing anterior wall, but we know it doesn't really, it's not malastic now, right? But the theory is to lift this soft wall forward, take the pressure off it, and have the back wall pulled down by the esophagus, which is pulled down to the spine by all this relar tissue. And it sort of makes some sense, and certainly when we go to doctor school, that's what we think is really going to happen. And this is how we do it. We do a little incision up here, do a little sternotomy, and pull everything forward, including the innominate artery, because the innominate artery is what's crossing at T2, and T3 is the aorta. So we really want to pull both forward in the cases when that's the problem. And we compared this to thoracotomies, which when I was in pediatric surgery training, I learned to do thoracotomies to treat tracheomalacia. So you come in from the side, and you try to bring the aorta forward. And I was taught to do it from the left side, which I now understand is completely wrong. Because when you're operating on the left side, the first big thing you see is what vessel? It's the pulmonary artery. So you're probably doing the pulmonary artery most of the time. Because if you see the pulmonary artery and you push it down, your anesthesiologist is not going to be very happy because you decrease the cardiac output. And or you do pericardiopexy, which is not quite as effective, but it's okay. And if you do this with bronchoscopy, you can see that you're having an effect. You can also do thoracoscopy. We wrote one of the early papers on thoracoscopy. All excited about it, put a little stitch in the aorta, which is so much fear in my heart. And then you just sew it up to the front. There's various ways of sewing it up to the sternum, or just do a pericardiopexy. It just takes the engine away. But it doesn't actually work that well. We actually looked at it and said, how well do all these things work? We compared them to each other. And although the partial sternotomy kids were the sicker group of kids, more tracheostomies, more severe diseases, we then looked at the manifestations of it. And after we sort of fixed them, the sternotomy at least fixed all the kids from vent dependence, and the majority of them were off oxygen, although it takes about 3 to 6 months for the lungs to completely recover after you've allowed them to clear. Certainly much better than the thoracoscopic, which didn't have great results, and the thoracotomy, which had pretty good results. We look at the components of the surgery. If you're coming from the side with thoracotomy or thoracoscopy, you're limited to what you can do, and it's hard to get up over the top from the left to get the innominate artery way over there. So you tend not to do it. You just do what you can do right up front. You come right from the front, you can lift up the pulmonary artery, you can lift up the RPA, the LPA, you can lift up the heart. You can do whatever you want because you're right on the front doing everything in the front. And with simultaneous bronchoscopy, you can see what works and what doesn't. And what we found was sometimes none of that worked. What you needed to do is put a stitch in the trachea and just pull it forward, and that worked. And so the direct tracheopexy was something we started getting our handle on while we're doing these sternotomies. We didn't do as long a follow-up for the partial sternotomy kids, but really pretty good results. No recurrences in thoracotomies or sternotomies, a high recurrence rate in thoracoscopy kids. Majority of the partial sternotomy kids had improved work of breathing, and they got their tracheostomies out. And that was a big thing for me, to get their tracheostomies out. We also found, the most interesting thing we found out, and sort of unexpected, is if you let these kids breathe well, they grow. And being bigger isn't necessarily the issue, but remember, these kids are also developing things like brains. And so you got to get them to grow if you want to make them smart. And partial sternotomy is the best way to do that at that time. So we really had a lot of technical advantages come from the front. You have all the structures laid out in front of you. You see the aorta, the pulmonary artery, you see the right and left main stems, and you can do whatever you want and get a good technical result. And follow it with bronchoscopy, and you can be pretty happy that at the end of the case, you've done the best you can. And we found out we need to do an echocardiogram before we leave the room, because we don't want to pinch off a pulmonary artery or something. So we really like sort of the aortopexy from the front because we have control. And we don't like the thoracoscopy because we had such a high failure rate. But let me tell you some secrets. Little secrets that you'll keep it just between us. It's all our secret. If you hurt the aorta, it bleeds a lot. And it may bleed so much that a pediatric surgeon can't control it. And once I did injure one, I would never go through the telescope again because it will bleed so fast you won't be able to get in there fast enough to help. It's also interesting how many of them required a tracheopexy in order to get enough anterior displacement of the trachea to open it up. And sometimes that was enough to cause a pinching of the surrounding major vessels, which could influence cardiac output. It also caused, interestingly enough, major displacement of the trachea. So the trachea is supposed to run along your spine, but at the end of a kid with severe tracheomalacia and an anterior displacement operation, that trachea is now running up along the sternum, and so it forms this big arch. It's still got to get down to the pulmonary hilum. On one end, it's got to get to the larynx on one end, and in the middle it goes way forward. But the problem was, when you did bronchoscopy, you still saw that posterior membrane going in and out. It just didn't go in and out as far. And these kids were symptomatically much better. They didn't get respiratory infections, but it wasn't perfect. So we did look at some studies, the aortopexy studies. We're not the only ones who looked at this. Left thoracoscopic approach, some of them took revisions. All patients are doing well. And so I talked a little bit about the pulmonary artery being the first vessel you see on that side. The world's experience with aortopexy, this is reviewed in 2012. 125 papers were reviewed, 581 aortopexies, which doesn't seem like very many. 43% had altes. They were done from thoracotomy. A few of them were done sternotomy, and even fewer thoracoscopically. And the results, 80% were improved, 8% had no change, 4% were made worse, 6% died, and 15 had significant complications. It doesn't sound like the perfect operation. Why? Well, improved does not resolve symptoms. We have a high complication and mortality rate. Is there something we don't understand? And the problem is, we didn't look at what we were looking at. We didn't see what we were seeing. And we're looking at these kids, and we're seeing the posterior membrane go in and out, and we're telling our brains it's the anterior cartilages that are collapsing. But they're not. The problem is, we were told that was going to happen, and you just can't see past that. So we thought, well, the problem is what we really need to do is stabilize that darn posterior membrane that's causing all the problems. So we developed, a few years ago, we developed an operation where we just tack the posterior membrane down to the spine. Well, the trachea and the spine grow about the same rate. Your carina is in the same spot relative to your spine as a baby's. So that's okay. So they're growing about the same rate. Why don't we just tack it to the spine? And this is conceptually such a simple idea. All we have to do is do it. And here's what it looks like. I know it's kind of hard to understand what we're looking at. We're looking at red stuff on red stuff, around red stuff, under the red stuff. But what this is showing is the posterior membrane being tacked to the spine and the esophagus being pulled out of the way, and we use a red vessel just to make it consistent. And this is anatomically, this is what it looks like. In you and me, we have, if we're malacia, we have U-shaped cartilages. We have a long posterior membrane. It's sitting on top of our esophagus. Esophagus sitting on top of the thoracic duct. There's some blood vessels and stuff. There's a spine, an anterior longitudinal ligament there. And when we exhale, that esophagus and the lung pushes everything up into the mediastinum. That mediastinum pushes up into the back wall of the trachea, compresses the trachea, makes it hard to get our secretions out. So what we do is we just pull the esophagus off to the side, take the thoracic duct, mobilize it, push it off into the right chest, into the left chest, and tack the spine down. Conceptually so easy. As Tom and Jason will tell you, not so easy. But this is what it looks like. We do it under bronchoscopic visualization, and that light in the distance is the bronchoscope that's showing us what the effects of each and every stitch are. And the stitches have to be very precisely placed, because if you put them on the one side, you torque the whole trachea to one side, you torque it to the other side. It's sort of a nuanced operation, but the results are great. Here's a kid with severe tracheomalacia on the upper left. You can see he has no airway, and when we're done, it's wide open. And we've done probably close to 100 of those now. It's a routine operation now. We do it a couple times a week. If we look at the results of our first group of 20 tracheopexy patients, you can see that we fix their altes, we drop the oxygen requirements in the short term. In the long term, almost all of them come off. Pneumonias radically decrease that. We fix the middle, lower, and right main stem bronchus. So we're feeling pretty good about ourselves. So the posterior tracheopexy can be done at the time we do esophageal work. Every time we do a Fokker, we consider does it need to be done. It takes a posterior thoracotomy to do it. We've tried to do it thoracoscopically, haven't been able to do it yet. I'm sure Jason will figure out how to do that. It can be done at the time of a primary esophageal and TEF repair. Should it be done? I'm going to make the argument that maybe it's about time to move forward with that. It stabilizes the posterior membrane and still allows for an aortopexy. In those few kids, the 5% of kids where it's not completely effective, now it's really simple to do an aortopexy. Just pull the aorta just a little bit because you've already got your baseline of posterior membrane fixation, and now all you're trying to do is pull that anterior membrane up a little bit. So you don't have to do these radical aortopexies anymore. It's really good for recurrent TEF repairs. I'm not going to talk about TEFs because we don't have time, but using part of this technique, we've essentially eliminated recurrent TEFs in our practice. We've got 50 of them or something right now. And where the worldwide recurrence rate is about 25 or 30%. But we do have a thoracic duct risk. We've injured, I think, 4 thoracic ducts, but we just fix them. Just put a couple of 7-O-prolines in them and they're fine. Have not had any major issues. Maybe someday we will. But certainly in the 100 so major thoracic duct injury is less than 1%. But what we haven't told you is the left main stem. The left main stem is different. Every segment of the airway is different. And we haven't solved all of the problems. The left main stem, we only solved about 30 or 40% of the problems, despite all our hard work, because it's more complicated. It has, you can have primary bronchomalacia, where it just collapses. This is like a child that Terry had with really long left main stem that's very, very floppy and needs a lot of external support. We can have anterior collapse from a large dilated pulmonary artery. It's some sort of a vascular problem that the cardiac guys deal with all the time. We can have posterior intrusion from the aorta, because the aorta is supposed to be next to your spine on the left, but sometimes it's on the top of the spine, which really intrudes into the left main stem territory. And sometimes the two are just, the pulmonary artery and the aorta are compressing it. And if the descending aorta is a little bit anterior on the spine, then if we do a posterior carinopexy, like we're pulling the membrane down, we're going to torque that carina down and we're going to make the left main stem worse. So all these things have to be considered. Here's the left main stem. You can see that's a pretty bad left main stem. You can see that posterior membrane intruding there. And this is what it looks like on CT scan. You can see that left main stem's completely ablated in this child during exhalation. And you can see why. I wish my pointer worked here, but you can see that this is the trachea going between the pulmonary artery. So this is the main stem getting narrow. Aortic arch, descending aorta, here's the pulmonary artery, and that is the segment where the trachea is being sort of pinched. So that's one form of just being pinched between two vessels. So it's a left main stem compression. It's interesting because when you say malacia, when you take the pulmonary artery off and you take the aorta off of this left main stem that looks like a fired staple, do you know what it does? It looks like a fired staple. It didn't spring open. You can't try to pull it open. As soon as you let go, it snaps back to this. So it's not malacia, it's malformed, strong tissues. So there's a lot of potential solutions for this problem, including internal stenting. We talked about the stent problems. Move the descending aorta. We've tried that several times. It works sometimes, and sometimes it sneaks back up there. We're not particularly good at keeping it down. Move the pulmonary artery. We're pretty good at moving the pulmonary artery off. The problem if you move the pulmonary artery off, what are you going to stent the anterior left main stem to? Because it's only the pulmonary artery in front of it, and you can't stent it to the pulmonary artery. You can anterior posterior pexies, but the angles don't work out right. You end up torquing things around. You can try an external splint. Michigan tried a splint a few years ago. There's computer-generated 3D modeling printer stents. They've done 3 of them that I know of. Unfortunately, predictably, one of them had a problem and it eroded into the pulmonary artery. But this is what it looks like. There's a lot of interest in that here. We actually have a 3D printer and a computer model, and we're ready to try to do this here, should the right patient show up. So this has had pretty good results in 2 of the kids, and 1 had a pulmonary artery erosion. So the EAT program, we just rushed through just one little slice of it. But I want to say I'm incredibly proud of this program because we started out as an idea 9 years ago. Dr. Chamber actually supported me dropping everything and flying out to Michigan, learning how to operate on a surgeon who had sort of a variable reputation. And I dropped everything, flew out, operated with him a few times, actually operated on a few kids after that. And then we started this idea that we'd fix a few long gaps a year. But it turned out we could do more. We could fix all these things, and we could tap into things that are missed opportunities. These are huge fields. The whole idea that esophageal atresia babies are fixed after you've sent them out of your office and go to the GI guys, they're not. They're chronically ill kids. They have reflux, they have strictures, they have all kinds of problems. And then somehow we tapped into the respiratory issues. Now we've got tracheomalacia, recurrent TEFs, and we have all these other issues that are coming up. And then we tapped into other things. We've tapped into congenital strictures. And Mike Manfredi and I are working hard on trying to that. And then we got tapped into now caustic ingestion. Somehow we're learning how to treat caustic ingestions. And I was just talking to a patient from Cincinnati. I gave them some ideas on how to treat a patient with caustic injection. So we are slowly sort of getting this cadre of patients who are coming out. And it's not because we have a program in caustic ingestion or congenital strictures. It's because we provide solutions to problems that other people haven't figured out the solutions to. And we provide the solutions because we go back and think about it. So this is what the EAT program is now. It's just this wheel. You bring us a tough, unsolved problem that is in some form associated with what we do, and I'm betting that we can find either way to ameliorate it or solve that problem because we have a great team. And who do we tap into? On the right side of this, you can see everybody we tap in. I don't think there's anybody in the hospital who hasn't worked with the esophageal atresia or the esophageal and airway treatment team yet, because we will tap into anybody, anytime, get their nuances, get their opinions, and we'll engage them to try to find solutions. And what they get out of it is lots of patients they have to take care of. The neurosurgery service takes care of tons of hydrocephalus and tethered cords and all kinds of stuff that come in to see us. So it's a nice two-way street. It goes out for every single thing. And it's made a huge impact on the pain treatment service because now that we started paravertebral blocks here, we were the first ones. We sort of pushed it through, got paravertebral blocks for thoracotomies, huge impact on decreased narcotic load, decreased addiction to these kids. So it goes on and on with everything, and our Venn diagrams of all the other services are slowly merging, particularly with what's now called CAD, or has been called CAD, the ENT ORL service where they could take care of airways, and with cardiac surgery. We just did a case with cardiac surgery, 2 or 3 a month now. It's big. So I'm very, very happy about how that, and we, of course, use the entire hospital to get it over. But are we done? Can we come up with any new ideas? Yeah, we come up with a new idea pretty much every week. And I just want to share one of our newest ones. This is a slide tracheoplasty for the management of complete tracheal rings. You've probably heard about tracheal rings. You're born. For some reason, the rings, instead of having a posterior membrane, are completely circular. And they can be of normal size, in which case you never know because nobody bronch you because you have normal airflow, nobody cares. But if they're narrow, as they often are, they restrict airflow as a stenosis, not as a malacia. And they can be critical. And this is a little baby we saw a couple days ago who had was transferred in from outside hospital MGH to Children's because it was a complicated airway. And the problem is when you fix complete rings, one of the ways to do it is a slide tracheoplasty. And up here you can see this is a tiny hole. So typically in 1 or 2 millimeters, kind of tiny. And when you fix it, that's considered a good result. But if you look at that, it doesn't look like that great a result. But that's considered a good result with a slide tracheoplasty because the airway is bigger. But everybody knows they don't do that great like that. So I wish I had a pointer. So if you do a slide tracheoplasty, what you do is you take that narrow segment, you cut it in half, slit it on the front and the back, and you slide the two ends together. And the concept is that you form those two circles and you form into U's. You take these circles and you form into U's and you sew them together. And there you've just, by doing that, you've made your restricted area about 8 times bigger. So you get a lot more airflow. But in fact, what happens is you get a figure of 8. And you get double the airflow with a large minus whatever you resected. So actually you get a little bit more than, maybe not quite double the airflow. So it's less than perfect, but that's the best they could do. What does a bent penis and a sonic trachea have to do together? Well, when I was with Dr. Hendren in the olden days, we could straighten out a bent penis by doing little imbrications and contract one side of it, and the other side would just bring it down. And in a case on Monday, we thought, oh, you know what we can do? Why don't we try the Peyronie's trick? And so what we'll do is place a little stitch on this U, place a little stitch on this side, and open that up. And I have to say, and just open it up, I have to say it worked remarkably well. So we just do a series of stitches on either side, take those two circles, turn them into 2 U's, and sew them together. And it worked remarkably well. I predict this will be a big hit. So this is the child. It looks just like the black and white picture I showed you, right? Could barely breathe and all kinds of drama in the NICU, so they transfer him to the CICU. And this is the end. This is the flexible bronchoscope. We do everything under bronchoscopy, and you can see that suture line. But more importantly, if this video will play, you can see that is a pretty beautiful airway. And you can see that without any external stenting, it's wide open. So a lot different than having a figure of 8 kind of airway. So I think this old EAT program has a few new tricks up its sleeve. So why do we do it? We do it for the kids. I mean, the bottom line, we do it for the kids. This is our EAT reunion. These are about half of the kids. It's hard to corral a bunch of children to get them on stage. But they're almost all eating by mouth. They're running around. We were serving cookies and solid foods, and they were just chowing it down. It was good to see them. This child right next to Dr. Folker's our first long gap, Ryan Page, who you'd never know has anything wrong with him because he eats hot dogs, plays football, and is a star student. His mom was so impacted by what we did that she went to nursing school and is now an ER nurse. Couldn't quite get her to the EAT program. But these kids, each of them have a dramatic story, and each of them are incredibly grateful for our being able to fix them. The young woman next to the guy under the balloons was a bad esophageal atresia and tracheomalacia patient of Dr. Folker's, and she is now a singer. So she sings on cruise ships, and she was trying out for some play or something in Italy. So she came out and visited us for that. So now you know what I know about severe tracheomalacia. I'll open this floor for questions.
That was a great presentation and update on where you currently stand with fixing